Hello everyone, my name is Miroslav Obarski and I'm a Senior Clinical Skills and Simulation Technician in RCSI. Today I'm going to talk to you about National Surgical Training Center, where we are fastly advancing in robotic assisted surgery, and we are finding the need to build and innovate in terms of making models for certain tasks using robots. So today I'm going to talk to you about robotic assisted partial nephrectomy procedure. And the model we created for this training is used commonly in our urology training days using robotic platform. So we're going to be talking about how we can actually implement tumors within the renal cortex. I'm going to talk to you about how you make the model. So what do you need? You need a good blade, ideally size 10, dissecting Metzenbaum scissors, toted forceps, marking pen to make sure you get your margins right, with a ribbon gauze, tissue glue, ideally 3M Vetibond. We create our biological tumors, which are based off soft silicone wrapped in a chicken skin. So at the top layer you still get your biological tissue, which is important for adhesions within the renal cortex. So now we're going to advance how we make the model. Okay, so to start with our partial nephrectomy model, what we need to do first, turn the kidney around from the way you were looking at them initially, and we're going to use instruments to open the renal fascia. We need to be quite gentle not to tear it, and use Met scissors to cut right into the fascia. And then you can see that it's already opening for us. So what we need to do is just go along the whole length of the kidney. Keep opening the fascia with the Metzenbaum scissors. Now we can put down the instruments and we can work with our hands. And we're going to peel the fascia, and we're going to deliver the kidney out of the fascia, and we also start turn the kidney around. As we're peeling it, we're going to end up looking at the kidney as we were at the initial introduction. So there we are. Peel it all the way back. There you go. And we are now looking at the cortex of the kidney. The next thing what we're going to do is we're going to put the tumors right within the cortex, and we can pick and choose the locations of the kidney. From what I understood from our urology colleagues, when they sit at the hilum, it seems to be more difficult to dissect them, so we can choose the level of difficulty for the trainees. So I think what we could do is do one with the smaller kind of top of the kidney, and the bigger tumor could go here. So that's when we use our marking pen to mark around the tumor. Micro dots. That will be our imaginary sort of margins. And that's how it's gonna look. We can put the tumor down. This is the longer mass, bit more irregular shape, so we can place it somewhere around here. Again, use the marker to go around, use a little dots, put the tumor away. So now we've got the territory we're going to be dissecting now to create a space for the tumor. So that's the time we're gonna use the forceps and 10-blade knife, not for the entire removal of the tissue, but just to make the initial cut. So just go gently with the scalpel where we created our margins with the marking pen. This is quite delicate tissue, so we need to be careful not to do the excessive cutting where we don't want to. So we keep going with the knife for another little bit. And I think we're at the level where we can just switch to the METS dissecting scissors again. Depending how big the mass is, we choose how much cortex we're going to remove. If we want to go all the way through the collecting system of the kidney, that has advantages if we want to subsequently introduce an active bleed at the bed of the tumor. But at the moment, we're going to stick with just deep enough, but not all the way to the collective system. So now I'm just dissecting the renal tissue. Okay, you can put that bit away. So you can see that I'm just sitting at the bed of the collective system. If I go deeper, I'm gonna end up right there. So I can just remargin my tumor, and I see it kind of sits right in. So that's what we know, what we want. So what we're gonna do next is use an ethibond and a drop. Use a few drops within the bed of the tumor. You can be quite generous because it will be dissected rather around the tissue to make sure all the margins are covered. So we're going to go back in and gently press on a tumor. And it only takes a couple of seconds, and the tumor is going to be well adhesed. We don't want to drop around on a healthy sort of tissue because it will burn the renal cortex. So we're now going to move onto the larger mass, and I think I'm gonna go all the way through the collecting system of the kidney now, because it is a bit deeper. So we can start again with a blade 10 and start incising. And I think I'm happy enough now, and I can proceed with the dissecting scissors now. I'm always trying to stick within those marked areas. We are right at the collective system. I'm going to go through the collecting system now, which will subsequently allow me to introduce bleeding mechanism, but also because I want this tumor to be deeper within the cortex. So collecting system is quite stiff when it comes to dissecting. Now we're done. So you can see I'm already through the collecting system. I can explore with the instrument, and I could literally do I could make connection with the ureter there. So we have the tumors in now. So now we need to pull the fascia back over the tumors, which can be quite tricky, and we need to be quite careful not to damage the actual fascia. So if you get a bit of a tear, there's no need to get disheartened about it. There is a way how to fix it. So I'll go same way as I went before. Start slowly peeling the fascia over. It is a gentle layer, so we want to handle it with care. Now I'm kind of meeting the fascia at the back, or at the back of the kidney. So what we want to do now is sort of get the air out by gently pressing the air out now. Again, pressing it out, pushing it out. Now we can peel this a little bit, and with a little bit of a drop, again, we create a bit of a tension on the fascia, like this. With a drop of the glue, we can do the same thing at the top. Gentle drop underneath the fascia. Now, what we can do now is make a tiny little hole with the scalpel and a little bit of the tissue glue inside through the hole, and just drop inside, and it will now close the sort of gap and remove the rest of the air. I just use just a little bit of a top. Now we can now turn the kidney around and do a little bit in the other side as well. Tiny bit of a glue inside. So we've got 2 tumors now ready to go within the kidney. We can then move away, we start away on the other one. Okay, guys, we're now onto a second kidney, and we've done a first kidney with 2 tumors sitting right at the renal cortex. And what we're going to do now, we're going to add another 2, but one of them will have a bleeding mechanism. So when the trainee dissect the tumor, we can introduce a little bit of a gentle blood ooze to make it slightly more difficult and perhaps even more stressful for the trainee. So we're going to be using the same ingredients, tools, instruments, what we did in the first video. The only difference is that we're going to use the simulated blood. So this is the saline just colored by simulated blood, IV given set, and then just the longer stabbing instruments from and traditional wound drain, and then 2 millimeter vessel, which is essentially going to be doing the bleeding mechanism. So what we do first, we're going to start to do the same principle, make the incision into the kidney, open the fascia, and start creating the tumors. So same what we did before. We will open the capsule a little bit, peel the fascia all the way back. So we're making our way through the cortex and right into the collecting system of the kidney. We can see we are right through, so we need to do a deeper cut now. This is the actual collecting system, so we have to go all the way through. And what we do now, we find the way through. We're right in the collecting system, so we'll find the entry to the ureter here, and we connect through until our instrument comes out. What we do, we pull. Once we're happy, we cut this. And now what we need to do, we need to hide that tube by pulling back a bit. So it will be supplying the bed of the tumor, but we need to make the vessel invisible. Now ideally at the other side, what we need to do is just few dots of the tissue glue, which will make sure, or we make sure that it's not gonna get dislodged. You can also throw an additional ligature over it, like you would if you're tying the drain. So what we do is now we're gonna do a test of our bleeding mechanism. So we're gonna enter the given set into the tube by expanding it like this. So we're now connected, and we will open the given set gentle. Now we can see the blood coming through now. This is not supposed to bleed heavily, it's just to add a bit of a gentle ooze. So as we can see now, blood is finding the way through. We can use the same principle, like if you're stopping bleeding, you can see it keeps bleeding. That's what we want. And we don't see the actual tube which feeds the bleed. So we can stop now. We're happy with that. We dry, and now we add the tumor in using a glue again, tissue glue, around the edges. We need to be now careful not to occlude with the glue the place where there is the blood supply. So we go everywhere. Just avoid that tiny space where your blood vessel is placed. We can place the tumor now. Few dots around here as well. Gentle push at the edges now. Make the mass be looking like well ingrown within the cortex. For this purpose, I'm not going to be adding the second tumor, but I'll show you again how we peel back the fascia. So following, we can do a gentle dab over here on the tumor. This will allow fascia to stick right away. That might be a preferable technique as opposed to the first one when we did the hole afterwards. But that's the preference. Both works well. So again, peeling back, twist the kidney. You can add 1 or 2 drops in here so that it will keep the fascia in place. And we're good to go. So we've got one large enough tumor right here, which is supplied. So when the dissection happens, we can take full control over the amount of bleeding we require during the procedure. So it is a bit more advanced for the trainee because the vision can be impaired by the blood in the operating field. Thank you. And good luck with your models.